Hello, friends. So I'll be talking on this topic, gram-positive infections and multi-drug resistance, current perspectives in management of Staphylococcus aureus and Enterococcus. So it's a talk I gave in Hyderabad. So very important talk for all the trainees to have an overview on the prevailing sort of infections that we deal with in ICUs with regards to gram-positive organisms, with focus on Staphylococcus aureus and Enterococcus and the ensuing resistance. So this is just a pictorial representation of how the staph looks. So it looks like a bunch of grapes, as you would be aware. So this is the Enterococcus faecalis, and the top one is the Enterococcus faecium. So throughout the slides, you would see this picture. So that's the morphology of them. So the topics I will be covering is introduction and epidemiology of staph aureus and the Enterococcus faecalis, and what is the evolving trends with regards to antibiotic resistance, and what is the mechanism of antibiotic resistance and the causes for the same. And we look into what are the common hospital-acquired infections due to staph aureus and due to Enterococcus faecalis, and common gram-positive infections in India, their treatment, and what are the general recommendations for treating the resistant infections and the staph or Enterococcus infection, and the summary. So when you look at the gram-positive infections, it is evolving as a major public health concern even in our country. If you recall, we had a main problem with gram-negative infections, and gram-positive was much lesser. So 75% was gram-negative and 25 to 30% was gram-positive. But this balance seemed to be changing, because in the Western world, it was always considered gram-positive to be more. But even in India, there is a resurgence and emergence of this gram-positive as a problem. And these infections do lead to increase in morbidity and mortality. And there is a sort of a change with regards to the resistance patterns that is evolving in these gram-positive bugs, which is leading to increased morbidity and mortality. And this has increased the cost for the patients who are in ICU and increases the length of stay in ICU when they have these infections. So when you look at the commonest sites of infections for gram-positive, most listeners would know that gram-positive infections commonly causes skin and soft tissue infections. And it can also cause ventilator-associated pneumonia, lung infections, or hospital-acquired pneumonia. And bone infections with osteomyelitis also is something that is commonly caused by gram-positive infections, mainly Staphylococcus. Intra-abdominal infections are predominantly caused by Enterococcus species. Enterococcal infections do commonly cause post-surgical intra-abdominal infection or intra-abdominal infection. And urinary tract infection also is commonly caused by Enterococcus faecalis or faecium. And mastoiditis, I'm sure any of the sinuses or mastoiditis can be caused by staph aureus, and meningitis also is one of the cause for this gram-positive infection. So these are some commoner sites of these gram-positive infections. And it can also cause toxic shock syndrome, which is attributed to the toxin by these organisms. And it can also lead to bacteremia and sepsis, and bacterial endocarditis is a common cause of causing bacteremia with gram-positive infections. So if you have staph aureus in the blood, obviously you would look for any vegetations in the heart to look for any endocarditis. So these are some of the commoner sites of infections just pictorially represented. And when you look at hospital-acquired infections, the gram-positive infections can cause healthcare associated infections or nosocomial acquired infections. And the National Healthcare Safety Network and CDC in US have looked at 13 types of different healthcare associated infections or hospital acquired infections due to these gram-positive organisms. And they have identified 50 sites in which these gram-positive infections can occur. The previous slides, we did show you the common sites of this gram-positive. So they have identified 50 sites. The common sites as per the CDC is they have looked at lung as a common site, followed by surgical site infections and skin and soft tissue infection, and the GI tract, intra-abdominal infections caused by Enterococcus, and urinary infections and meningitis. So these are considered as the most common sites in ICU caused by gram-positive infections. So this is as per the CDC. So the common organisms for hospital-acquired infections, when we look at overall common organisms that cause hospital-acquired, it's Acinetobacter. So that's the morphology of Acinetobacter. Pseudomonas is the second, and Enterococcus faecalis, followed by staph aureus and Enterococcus faecalis and Enterobacteriaceae species. So these are the common organisms which are implicated as the organisms causing hospital-acquired infection. So if you see, Acinetobacter remains the commonest, followed by Pseudomonas, followed by Enterococcus, and so on and so forth. So, and when you look at this, again, selected antibiotic resistant nosocomial pathogens, Klebsiella seems to be one of the commoner one, followed by Pseudomonas, MRSA is common, VRE, and Clostridium difficile. So these are also some of the commoner ones that are looked at. So when you have to look at hospital-acquired infections, so we need to have some understanding of how do we control nosocomial infections. So there are three different dimensions when we talk about control of nosocomial infections. One is to look at the, we have to have an audit of looking at the infection rates. So measuring the infection rates and comparing with how these infection rates are trending is an important sort of a domain that one needs to look at in controlling, because unless we have a data of how the infection rates, whether it's in a decreasing trend or increasing trend, we may not be able to put in measures to control the infections. And it's also important to look into the type of infection, location of the infection. And the second dimension of the domain is to look at effective infection control program and having an effective disinfection, surface cleaning and disinfection of all the instruments and of all the invasive procedures. All this goes in a long way in preventing these nosocomial infections. And most importantly, the education of the healthcare professionals on the importance of hand washing and all the infection control measures that need to adopt is something that is very important in control of nosocomial infections. The third dimension is looking at all the surveillance data. So looking at the surveillance data, analyzing the data, collection of the data, and interpretation of the data. So the key essence or the quintessence of controlling nosocomial infection is to keep on collating the data of the emerging infection trends and acting upon it. I think that remains the key. Unless we are collating and we are not capturing the data, we may not be in a position to control the infection. And planning, evaluation, and implementation of public health measures goes a long way in controlling nosocomial infections. So we'll talk about more about Staph aureus and Enterococcus. So when you look at Staphylococcus aureus, these organisms can grow between temperatures of 18 to 40 degrees. So they're fairly sort of organisms that can grow in any climatic conditions. And the interesting thing is they can grow in both aerobic and anaerobic conditions. And this is how the MRSA looks. So MRSA organisms is always associated with poor outcome. And 23 to 47% of the Staph aureus infections that happens is attributed to MRSA, which is methicillin-resistant Staph aureus. And globally, it is attributed that it can cause 929,000 deaths annually. It is causing MRSA. So which is a huge public health problem. And MRSA, the main resistance to methicillin comes from this gene, MECA gene, which codifies the resistance for MRSA. And when you look at the whole problem is the vancomycin resistance also, which is developing, which we call as VRSA, or the vancomycin resistance is more common for Enterococcus, vancomycin resistance. And this is caused by these genes, which is from VAN A to VAN Z gene. But the commonest is the VAN A, is the gene which confers resistance to Enterococcus faecalis. And these are either plasmid mediated or chromosome mediated. And faecium, Enterococcus faecium is what exhibits more resistance to vancomycin than faecalis. And 2 to 20% of the faecalis exhibit resistance to vancomycin. So this is the sort of a ballpark figure you could have, as any faecalis and faecium are the more notorious for causing vancomycin resistance. And PCR techniques are useful in identifying which genes is conferring for this resistance. And we saw MRSA contributes to 900,000 deaths. VREs or Enterococcus contributes to 100,000 to 250,000 deaths globally in a year. So now we need to understand what are the mechanisms that are involved within Staphylococcus and Enterococcus to confer resistance to vancomycin or to any other antibiotics. So when you look at, this is the pictorial representation of the cell wall of a bacteria. So these bacteria do develop resistance to permeability of the antibiotic. So the low permeability of antibiotic into the cell wall of these bacteria confers resistance, because antibiotic cannot enter it through the cell wall, or the presence of efflux pumps. We have, because these are the common resistance mechanism present in most organisms. This efflux pumps, as the name sounds, it will throw out the antibiotic once it enters the cell. or there can be degrading enzymes like beta lactamase, which is an enzyme produced by the bacteria which degrades the antibiotic, or the antibiotic acts on certain target sites and the target sites can be bypassed, or there are certain targets which get modified because of the genetic variation. So these are some of the common mechanisms which contribute to resistance of these organisms. So when you look at causes for antibiotic resistance, we know increasingly there is increased antibiotic usage in the poultry or in the livestock or in agriculture sort of a setting, which is contributing to increased emergence of antibiotic resistance, and increased globalization, which means people are traveling from one place to another. There is a lot of patient movement, and this also leads to increasing in the resistance pan globally, and over usage of indiscriminate usage of antibiotics. This also contributes, and not adopting antimicrobial stewardship in a hospital or in ICU. So these are some of the key factors which leads to increase in the antibiotic resistance. So for me, the most common thing that we as a clinicians deal with is last two, because the first two is possibly more of a public health issue. The last two is something that intensivists should be sensitized to: overusage and indiscriminate usage of inappropriate antibiotics, and not adopting antimicrobial stewardship sort of principles within their ICU can lead to increase in the antibiotic resistance. So is emergence in resistance, does it have a bearing on mortality? So we need to see. So this is the study that is come. This is a good study which has come from Indian authors and collaborating with US authors. So here they have looked at resistant Staph aureus and Enterococcus faecalis, which is BRE or VRSA. So they have looked at these and they have looked whether this had a bearing on mortality. When they looked at MRSA, the odds ratio was not significant. So it did not per se lead to increase in mortality. But if there was resistance to MRSA with aminoglycosides, then the odds ratio became significant, which means if a Staph aureus or Enterococcus had resistance to methicillin along with aminoglycoside, there was an increase in the risk of mortality in this particular study. And glycopeptides, which is vancomycin or teicoplanin, so they did not have increase in mortality. But this is an important thing for our intensivists. So when these patients get admitted to ICU with either Staphylococcus resistance or Enterococcus resistance, the mortality can be pretty high, because if you see for Enterococcus faecalis, the odds ratio was 4.78, and this was statistically significant. So Enterococcus faecalis with resistance to vancomycin, when they come to ICU, the risk of death is very, very high. And the site of infection also is very important. If you have a resistant Staph aureus coming to ICU with lower respiratory tract infection, so the odds of mortality is high, and that was statistically significant. Or a patient comes with Staph aureus who is with a resistant Staph aureus with a bacteremia or CSF infection, so the odds of dying or the odds of mortality is high. So the essence of this slide is someone who comes with Enterococcus resistance to ICU, the risk of dying is more. All the things that are marked in red are statistically significant. Someone who comes with LRTI, MRSA coming with LRTI, higher mortality. MRSA coming with bacteremia or meningitis, higher mortality. If you can remember that, that should be good enough. So let's look into the Staph aureus as the as what sort of infections are common. When you look at hospital-acquired infections for Staph aureus, the commonest infection, which I'm sure most of you would agree, is cellulitis, because this is the commonest skin and soft tissue infections, either superficial infection or necrotizing fasciitis or deep-seated infections, or the common presentations to ICU, or deep-seated abscess. And scalded skin syndrome is also something that is quoted as causing common infections. Toxin mediated can happen due to Staph aureus due to food poisoning or toxic shock syndrome. And the virulence of Staph aureus is mainly due to the toxins or due to the enzymes or due to the immunomodulators. And other infections, Staph aureus, we have problem in ICU is hospital-acquired pneumonia, ventilator-associated pneumonia, or surgical site infections. So skin and soft tissue infection, surgical site infection, hospital-acquired pneumonia or VAP is something that is common to ICUs. So what are the common gram-positive infections in India and available treatment options? So we looked into the treatment options. So if it is methicillin-susceptible Staph aureus, which is a Staph aureus which is not resistant, which is methicillin sensitive. So this is the easier sort of infections to treat. The treatment of choice is amoxicillin or cloxacillin. So both are available. So I'm sure most of the listeners would be upfront. If you have a staph aureus, you would be thinking of using amoxicillin clavulanic acid, or cloxacillin also is something that could use, or any of the first generation cephalosporins. It can be cephalexin or cefuroxime or cefazolin. Any of the first generation cephalosporins can be safely used for MSSA, methicillin sensitive staph aureus. If patient is allergic to penicillins or to cephalosporins, then vancomycin could be considered for this. But always the first choice is simple penicillins, amoxicillin, cloxacillin, or first generation cephalosporin. So if you have MRSA, then the choice is you have vancomycin. If vancomycin is also resistant, then you have to consider daptomycin. But ticoplanin is not available in USA. That's why you wouldn't see this coming as a recommendation in many of the standard recommendations. The second line treatment for MRSA, if vancomycin is not available, is linezolid, or the fifth generation cephalosporin, which is ceftaroline or tilavancin. So ceftaroline is available in India, as I understand. Tilavancin may not be available yet. And ceftobipirol is the fifth generation cephalosporin, which is also found to be effective against MRSA. So these are the drugs that one could keep in mind for MRSA. So in 2016, Indian infection disease guidelines have come out with vancomycin and ticoplanin as the first choice for MRSA, followed by linezolid is something that one could consider for skin and soft tissue infection. And daptomycin is something that needs to be considered for MRSA when they have bacteremia or complicated skin and soft tissue infection. So this is the 2016 sort of a guideline that is suggested. But if you see standard worldwide guidelines, vancomycin is the first choice, and generally they talk about daptomycin. Ticoplanin, since because of it's not an FDA approved in USA, it usually doesn't see the mention. But as per all the studies, there is no much difference between either vancomycin or ticoplanin with regard to their efficacy for MRSA, and one could consider either. So how about vancomycin resistance in MRSA? So when there is vancomycin resistance, staph aureus, or vancomycin intermediate resistant staph aureus, combination has to be used. So it's not just only daptomycin. Daptomycin has to be used in combination with an aminoglycoside. It has to be used with gentamicin, or with rifampicin, or with linezolid, or with trimethoprim sulfamethoxazole, or with beta-blockers. So if it is a VRSA, vancomycin resistant staph, or vancomycin intermediate staph aureus, so it has to be a combination of daptomycin with any of these aminoglycosides. The simplest for us to remember is daptomycin with an aminoglycoside seems to be a easier combination to think of. If there is reduced susceptibility to daptomycin, then one has to consider quinopristine and dalfopristine along with linezolid or trimethoprim sulfamethoxazole or tilavancin. And quinopristine, dalfopristine is available in India. It is used at a 7.5 milligram per kg twice a day is something that one should keep in mind. So this is for if there is reduced susceptibility to daptomycin. So how about recommendation? So when you look at infection-based recommendation, so this is possibly non-ICU setting. If they have abscess, furuncle, carbuncle, treatment is incision and drainage. That is if it is purulent cellulitis, so these are the drugs that one could consider. These are all sensitive staph. If it is non-purulent, you could consider beta-lactam, first generation cephalosporins. But we will discuss about what is relevant to ICU. What is relevant to ICU is we see complicated skin and soft tissue. And I'm sure most of the intensives are listening to this. If you have a patient with necrotizing fasciitis coming to ICU with sepsis, we would obviously put them on vancomycin until we get whether it is MSSA or MRSA. So the choice is vancomycin or linezolid or daptomycin and clindamycin, tilavancin. So vancomycin is something it's easy to remember, and I'm sure most of you would be possibly using this as a standard of care. So when it is bacteremia and infective endocarditis and patient has MRSA, then the choice is vancomycin or daptomycin. And if it is infective endocarditis of native valve, it is vancomycin or daptomycin. So as you know, right now we are treating a patient in our ICU with infective endocarditis with staph aureus. So we're giving vancomycin until we get sensitivity. So if it is an infective endocarditis with prosthetic valve, then vancomycin has to be used with gentamicin or rifampicin. So this is the combination. But if it's a native valve, either vancomycin or daptomycin is good enough. So these are the sort of recommendations. So for the bone and joint infections, osteomyelitis, septic arthritis, again vancomycin. So these are all typical ICU sort of situation. The take-home thing for most intensive is vancomycin is good enough. And if vancomycin, there are some issues with resistance, daptomycin is something you can remember, and clindamycin. So other things you can just keep in back of mind. If it is a prosthetic joint or spinal implant infection, again the same thing, vancomycin. If it is CNS infections, meningitis, brain abscess, subdural, again vancomycin. So you see, we are repeating vancomycin for most of the ICU sort of based infections, and the second would be daptomycin is something, and linezolid is something that is useful for CNS infection as well. So this you can remember for all ICU based infection, if it is skin and soft tissue infection, or if it is a bone or septic arthritis or CNS infection, vancomycin is here to stay. Bacteremia, vancomycin or daptomycin. If it is a prosthetic valve, then one has to consider combination of vancomycin with aminoglycoside and rifampicin. So that if you remember that, that should be good enough. So let's move on to Enterococcus species. So Enterococcus species can cause sepsis, can cause bacteremia and sepsis. The common site for enterococcal infections is the surgical site infection, urinary tract infection. I'm sure many intensivists would have seen Enterococcus growing in the urine, and central line associated infections, CLABSI or central catheter related bloodstream infection. So the virulence factors for Enterococcus is cytolysine, adhesions, hemolysin, because we saw in staph, it was the toxin, enzymes, and other things. So here it is cytolysine, adhesions, and hemolysin, gelatinase, superoxide. So these are all the proteins which causes or which increases the virulence of Enterococcus. So what are the options for treatment of severe Enterococcus faecalis? This is also interesting. So the guidelines are different. So for Enterococcus, which are susceptible to ampicillin and aminoglycosides, with no HLR is no high level resistance to aminoglycosides, then the treatment is ampicillin with aminoglycosides. If it is a sensitive Enterococcus faecalis. If it is susceptible to ampicillin and aminoglycosides, but high level of resistance to aminoglycosides, then one has to use ampicillin in combination with ceftriaxone or fluoroquinolones or imipenem with vancomycin or daptomycin. So the treatment of choice for a sensitive Enterococcus faecalis is ampicillin is the first choice. And if there is a high level of resistance to aminoglycosides, ampicillin has to be combined with any of these drugs. But most intensivists who are listening to me would be using vancomycin as a choice, because vancomycin is to be considered when there is resistance to this ampicillin. So if you look at the general suggestion for Enterococcus, sensitive Enterococcus, ampicillin 1 to 2 grams every 4 to 6 hourly, or penicillin can be used. As you see, the alternate regime is vancomycin. So I'm sure most intensivists simply would be using vancomycin, because in ICU settings they'll be more sick and sensitivity would take some time. So one would be using more of vancomycin. So possible alternatives for treatment of severe vancomycin resistance. So this is something we see in ICU. If there is vancomycin resistance Enterococcus faecium infection, then this becomes a little more complex. So this is Enterococcus faecium with ampicillin MIC less than 64 micrograms per ml with no high level resistance to aminoglycoside. Treatment is again high dose ampicillin. For Enterococcus faecalis or faecium, ampicillin is the choice, but faecalis high dose ampicillin has to be used 30 grams per day with aminoglycosides, either gentamicin or streptomycin. But when there is high level resistance to aminoglycosides, it is similar to Enterococcus faecalis. We have to use high dose ampicillin in combination with daptomycin or quinoprestin, dalforestin or imipenem. So if there is high level resistance to aminoglycoside. If there is severe vancomycin resistant Enterococcus faecium with ampicillin MIC more than 64 with no high level resistance, then if there is resistance to vancomycin, if it is VRE or VISA, vancomycin intermediate Enterococcus faecalis or faecium, then we have to use daptomycin plus aminoglycoside plus another, it's called another active agent. It can be tigecycline, doxycycline, rifampicin, ampicillin. So any of these has to be added. So VRE, vancomycin resistant Enterococcus faecium, is more troubling to treat than faecalis. Faecalis, you just put vancomycin. But if there is a vancomycin resistance to faecium, then daptomycin with aminoglycosides with another active agent has to be used. When there is a high level resistance to aminoglycosides, then daptomycin with another active agent has to be used, or quinopristone, dalfoprestin with another active agent, or linezolid with another active agent has to be used. So this is the combination. It's a little difficult to remember this combination, but if you have vancomycin resistance, it's good to look into your infection manuals and look for these combinations, because these combinations have to be used to improve the outcomes. If there is resistance to vancomycin for Enterococcus faecium, if there is no resistance, the answer is simple. You can use high dose ampicillin, or you can use vancomycin. But if there is resistance to vancomycin, then one has to use daptomycin in combination with aminoglycosides with another active agent, which is any of these, cyclin, doxycycline, or any of these. So vancomycin resistant Enterococcus, what are the infection control measures? So the recommendation is, once you have a patient with vancomycin resistance, Enterococcus faecalis or faecium, so stringent infection control measures have to be put in place, and surveillance of all the patients for any cross infections has to be made, and patient has to be isolated if there is VRE, because we do encounter VREs once in a while. So we need to make sure that their patients are isolated, and good sort of an education for healthcare professionals has to happen on the effective infection control practices, and stringent antimicrobial stewardship has to be incorporated, and efforts have to be taken to prevent carriers of these infections. So which means effective screening of healthcare professionals and other patients has to be done and prevent carriage of these infections. And there should be a surveillance to detect resistance to newer antibiotics and resistance to disinfectants that are used to sanitize the ICU. And rapid diagnostic tools have to be utilized to pick up these resistant bugs by PCR or selective enrichment both. So the summary is, for methicillin sensitive Staph aureus, first generation cephalosporins, or amoxicillin, cloxacillin is good enough. But if they are having intolerance or allergy to that, then vancomycin could be used. For MRSA, vancomycin is the drug of choice. If it is Enterococcus faecalis or faecium with ampicillin MIC less than 64 with no high level resistance to aminoglycosides, then the drug of choice is high dose ampicillin with aminoglycosides. High dose ampicillin is 30 grams per day. And the ampicillin remains the drug of choice for Enterococcus faecalis and faecium. But if it's vancomycin resistance, then one has to consider daptomycin along with aminoglycosides with another active agent, which can be tigecycline and all those drugs that I showed. Quinopristine, dalfrestin is also another agent that can be used along with daptomycin. Is something that one needs to keep in mind. And rapid screening of vancomycin resistance Enterococcus using molecular diagnostics, PCR, and selective enrichment broth is useful in early identification of resistance patterns and containing the spread of these resistant organisms. So that's about it. So I end with this interesting quote: an outbreak is a sad way to get people's attention. So thank you, one and all.